My name is Mike Lean, and I'm Professor of Human Nutrition at the University of Glasgow. I'm also a consultant physician in Glasgow Royal Infirmary. DiRECT stands for Diabetes Remission Clinical Trial, and this was the first ever research study, which took people with type 2 diabetes who are overweight and set a remission of diabetes as its goal, as its target. We aim to get people with diabetes to get rid of the disease, in other words, to be non-diabetic after 1 year, after 2 years, and hopefully for longer. We set out at the beginning to see whether we could get 1 in 5 of our patients to be non-diabetic at 12 months, at 1 year. And that was done through weight loss. And we have plenty of reasons to believe that weight loss probably would achieve this, provided you can maintain the weight loss in the long term. And what we've discovered was that these are perfectly ordinary people with type 2 diabetes, attending their own GP surgery, seeing their own nurse or dietitian if there is one. By giving them a very well designed program, it's called Counterweight Plus, which we developed over almost 20 years in Scotland, that program got almost half of these patients to be non-diabetic after 12 months, and over a third of them remaining non-diabetic at 2 years. It seems to happen quite quickly, so as patients begin to lose weight, their diabetes indicators return to normal quite quickly. And the trick is to get enough weight loss off that then settles out at a lower level, and then to maintain the weight loss for as long as possible. We have done a very detailed cost analysis of the DiRECT trial intervention, the Counterweight Plus intervention during the trial. So that's the cost of delivering it in a clinical trial setting. So there are a few extra costs, and even with those extra costs, the cost per patient who entered the study was just over £1,000. It was £1,067, and that's for complete management for 12 months. And that corresponds with the average cost of somebody with type 2 diabetes attending their doctors at the average over their disease lifetime of £2,800. So it's actually cheaper than keeping patients in the disease process as an average annual cost. And from that perspective, it actually is highly cost effective. And of course, as well as getting almost half of them to be non-diabetic, and the remainder taking less medication than they had at the start for their diabetes, because they lost weight, many of them lost weight even if they didn't have a remission. They also had lower blood pressures, and we'd stop their diabetes medication, they would stop their blood pressure medication, and they had lower lipids, so their risk of heart disease was also substantially reduced. And we can say that within the 12-month period, that just the cost of this program was less than the average cost of being diabetic and attending your own doctor in the usual way. We're now looking at the projections as to what we expect to happen over the lifetime of that patient. With the reduced drug costs, they had less attendance at GP surgeries, less hospital referrals, and they've got less disease at the end of it. There is a strong possibility that it will actually work out cheaper to do this intervention than to do nothing. Magnesium is interesting. Magnesium is present in virtually all normal foods. It's in all fresh foods. There's magnesium there. It's part of life. It's part of all living things use magnesium. It's the way that our cells operate, our nerves operate. The whole body requires magnesium. And you need a certain amount of magnesium every day because some is going to be lost every day. And the average amount which is required on our recommendations is probably 350 to 450 milligrams a day. It isn't very much, but you do require that amount. And that amount is required really whatever you're doing. The total diet replacements, these formula diets, have been historically have used the same amount, and they've worked very well. If you don't have enough magnesium, then you are liable to get more diabetes. So we don't want people to have less magnesium than recommended. And the other, but we understand that the Commission was given advice through EFSA to reduce the amount of magnesium in total diet replacement products down to 250 milligrams a day. So that's a lot less than the average intake. And there are two possible consequences. One is you are liable to end up with more diabetes at the end of the day if you cut back on magnesium. And the other is a practical thing, that on total diet replacement, when you're only eating 820 calories a day, some people commonly become a bit constipated. Magnesium actually helps that problem. It loosens the bowel. And the reason that apparently the EFSA said you should reduce magnesium in these products is because they cause diarrhea, but they don't cause diarrhea. They absolutely don't. They cause the opposite. So I don't know who was giving advice here, but it certainly wasn't people who use total diet replacement for weight management or for diabetes care. We need, if anything, a little bit more magnesium, not less. There is quite good evidence now that having diets with greater protein content is good for long-term weight management. I don't think that the evidence is there to suggest that having more protein during a total diet replacement of 820 calories a day, I don't think the amount of protein in that matters at all. What does matter is making them palatable and allowing as many people as possible to get access to these products if we want to get rid of type 2 diabetes. The difficulty is if you put more protein in, firstly they become more expensive, which is another problem, and secondly the sort of stability and flavour becomes compromised, so they're actually more difficult, they're less palatable. And there seems to be no reason for it. We're getting very good weight losses, we're getting very good remissions of diabetes with the existing products. There is absolutely no need to change the protein content of these diets. I do think that the protein intake during long-term weight loss maintenance is something we need to look at, and there may be, there may be evidence which says that we should increase protein intake in the long term, but not during the total diet replacement. Choline is a small molecule which is part of our metabolism. Choline is made in our bodies. We do not need to eat it in our diets, and I have no idea why there has been a recommendation to add choline. I can only think there must be some vested interest in making or selling choline. It is not required in adult human diets. In some very sick children there can be choline deficiency. It's an intermediary metabolite which has some importance. It is important, but in very sick babies I think they can become short of choline. It doesn't happen in adults. Haha! Well, unlimited resources, that goes a long way, doesn't it? I mean, then you have to look back at preventing obesity. And of course I would then turn my head immediately to say, well, why has this phenomenon of obesity followed by type 2 diabetes, followed by arthritis, followed by depression, and all the things that come with obesity, what has been driving that? And it has happened over the last 40 or 50 years, perhaps 60 years. And it is to do with people being less active, not using their legs as much as they used to, but probably more importantly it's to do with the social marketing which has made it normal to eat a whole load of foods and drinks that we never did before. So when I was a schoolboy, I would have been punished if I had been eating between meals. Snacks between meals didn't exist, it wasn't done. And I've kind of kept that up for the rest of my life, and it doesn't seem to have hurt me very much. Nowadays, every child is sent to school with something wrapped up in coloured paper and shiny paper, purposely to eat between meals. And I think that sort of attitude to food as a commodity to make money from, rather than as a biological necessity, is something we've misunderstood. So I would actually go right back and say, okay, we're going to have to make some changes about the whole way people eat, and you have to undo that social marketing. That'll take us about another 50 years.